Started. Welcome everyone to the 10th and the final session of our COVID cases teaching. We're going to, I think, just hand over to Navina, who's very kindly joined us today for a few words.
Thank you, Juliette, and thank you, everybody. So there are, is it true, 57 people? That is correct. That's amazing. Thank you for inviting me. And I'm sorry that I'm only getting to my first one, which is your last one of these webinars. I've heard a lot about them, and they sound really fantastic. So I hope I can stay for as much as I can. First off, I want to say thank you to everybody who's organized this. And I know it's trainees mainly who put your idea and your way of supporting one another through these really difficult times during COVID. So fantastic. We'll keep an eye on you and your career progression, I'm sure. So well done. I hope that, also want to say a big thank you to everybody. I know that it's not just trainees from ELFT in this group, there are trainees from other trusts too. Welcome and thank you so much for everything that you've been doing across London and beyond, across the country, if you're coming from across the country. During these last few months, and these sessions, as I understand it, have been really useful for sharing learning, sharing good practice, and sharing how we can manage during a time that really is completely new to all of us. And what I've heard and seen is some fantastic innovation, creativity, but most importantly, what I've seen is still making sure that the voice of the service user and the patient, and that their needs are uppermost in all of your minds, and how we as professionals come round to protect ourselves, to do the right thing, but always having them front and center. And that is hugely important. And I'm really proud of my fellow psychiatrists for being able to do that. So thank you so much. I'm really, well, as I say, proud. I can't not mention what's going on for us all right now. And we started in our organization thinking about health inequalities, and we will all see our service users probably suffer the greatest health inequalities of the population in this country. But what's become really stark and shone a light with COVID and other incidents more recently is the way in which our Black and BAME, but particularly Black service users and our Black colleagues, what they're experiencing is really obvious to us right now. We in ELFT are quite preoccupied with this. I want to ask you all to help us to make a pledge that this isn't just in the moment for this week or next week, and then it's something that we forget about as we move on to other pressures. I want our trainees and our colleagues to make sure that we keep highlighting and putting pressure on the organization, the NHS and wider society to come together to tackle these inequalities that are particularly affecting our BAME colleagues and patients. So I'll be hoping that we get lots of ideas from you as we go forward. Thank you so much again for all that you do.
Great, thank you for that, thank you. So we also need to thank this week our expert reviewers. So these are from People Participation, Tonya, Goodship and Upma, Monga. And also from the Trust, Dr. Mazen and Dr. Anghard, Ruttley, and Dr. Sara, Rassool. And from outside the Trust, Dr. Claudia, Ajayi, Dr. Joe Billings, Dr. Kellie Gordon, Dr. Song, Dr. Christina Collins, Dr. Joe Stubley, Mukul, Shah, and Dr. Elena, Alexandrou. Thanks so much for all your help with this case. And of course, huge thanks again to Cate and Lynsey, the geniuses behind the series, who have gloriously transformed our ignorance into confidence over the last 12 weeks. As ever, we do welcome your contributions and your participation. You really make the sessions. So please put your comments in the chat box, don't be shy. Remember to share with all attendees, and thank you for joining us for the final case. Thank you.
Thanks, Juliette. All right, so 10th and final case. Just going to start with a very brief update this week, which is this this really important editorial in the Journal of Mental Health about the role for lived experience leadership going forward. It's quite a reflective article. I thought it was quite helpful in thinking about how lived experience can be brought in a leadership way to help us think about our practice going forward. So I definitely recommend giving it a read. All right, on with the case.
Yes. So once again, you're on call. You're an SHO working the evening shift in liaison, and the PLN has someone in A&E that she's seen and wants to discuss with you. And this is Ms. T. She's a 58-year-old white British high school English teacher who's been brought into A&E by ambulance with breathlessness, background of recent discharge from the medical ward and ITU where she was treated for COVID. And she's refusing any investigations, and the A&E staff have asked help in supporting her. So when we look at the A&E clerking, they've described, again, a 58-year-old woman brought in by ambulance with breathlessness, tachycardia and hypoxia. She'd been noticed to be breathless by someone who was delivering food to her. She's quite teary, she's not really giving much of a history. She seems to be saying that she was short of breath since this morning. She's not got any chest pain, cough or fevers. And she's been quite fatigued since leaving hospital, not sleeping very well. And she's currently under the community pulmonary rehab team. She's still kind of got quite a reduced exercise tolerance though since her COVID. And the clerking notes that she was treated with clexane during the medical admission and then some rivaroxaban for 14 days after discharge. So as we described, she had a medical admission with COVID in early, or sort of mid to late April, quite a severe illness with respiratory distress syndrome, pneumonia, AKI, and she was intubated and ventilated in ITU for 5 days and then stepped down to the ward and her kidney failure resolved. In terms of other past medical history, she's got diabetes, obesity, hypertension, hypercholesterolemia and depression. So she's taking metformin, atorvastatin, ramipril and cholecalciferol, and all we know from the A&E clerking is that she lives alone. She's got a package of care and volunteers coming in to help with shopping, doesn't smoke, doesn't drink or use any drugs. So A&E felt that she was kind of very teary and breathless on examination, raised respiratory rate, but did note that she's quite anxious, raised pulse, blood pressure of 110/60, SATs of 94, which dropped to 90 on exertion, and she's afebrile. She's got some poor air entry, but no kind of focal lung signs. And I guess the main other finding is that she's got a swollen right calf, which is dusky and tender. So we're not going to ask you to kind of guess what the diagnosis is, because their impression is that she's got probably DVT plus or minus a PE, and they've calculated her Wells score, which makes a very high probability for a PE. So their plan is as kind of below there. They're going to do an ABG, bloods, CTPA, ECG, and give her a stat dose of enoxaparin. And they felt that given her kind of functional status that she was not really suitable for outpatient treatment. So the PLN tells you that she has helped coax Ms. T to have an initial blood test, but she's very, very anxious and she seemed to be having a panic attack. She's really frightened and she's saying she just can't go there again, meaning hospital, and she'd kind of rather die than have to be admitted. And the PLN has kind of spent a lot of time with her, helping her to calm down a bit, but just as the A&E doctor's coming to do the ABG, she got more distressed again. And although she kind of initially allowed her kind of arm to be held and sort of they were about to do the ABG and then she pulled her hand away. So the PLN is wondering whether the A&E doctors could write something up to help her relax, and wants to discuss this with you. So what other information would kind of help you to kind of advise in this situation, and do you have any advice for the PLN? Bearing in mind that the other PLN has asked you to come and see someone else who probably needs admission, so you don't have too much time to spend looking over her notes, but have a think about what information would help and what would you advise.
So we do have some, so here's her vital signs on the previous slide there.
Yep. So her she's definitely hypoxic. That's not her normal oxygen saturation, and she hasn't got any allergies. And she's just on some metformin and
there we go.
These other things. So she's, yeah, I guess she's she is breathless, but she's still speaking in full sentences, and she's quite distressed. So she's not necessarily refusing oxygen. They haven't felt that she needed it at the moment necessarily. But yeah, so there's a good question here about were psych previously involved during her COVID admission. So definitely that would be a helpful thing to know. Was she someone who struggled a lot with medical treatment previously and needed a lot of support? Was she depressed or whatever during that admission? So that's definitely a good question.
And a point here, just thinking about what you might advise, someone's pointing out they would avoid a benzo. I mean, we've mentioned before that obviously we're worried about respiratory function, particularly in this lady. So we have to be quite cautious when thinking about benzos. Some suggestions coming in around using promethazine as an alternative to a benzo.
Yep. So I guess we will move on. So she is not registered on Rio, so we can assume that she didn't have any contact with liaison during the recent COVID admission. And the GP summary describes a history of depression and anxiety dating back to 1990, and has an entry for a victim of domestic violence, but no kind of other details. And a quick scan of her previous admission suggests that she did have some agitation when she was in ITU, but they managed it just with IV haloperidol, midazolam, didn't ask for help from liaison. And it seems that community physio have noticed that she's a bit low in mood when they've seen her and has ongoing fatigue. And she doesn't have next of kin listed, but the social worker who saw her in the previous admission noted that her friend is looking after her dog, and that person was the main kind of point of contact in the last admission. So we've got some of her bloods are back because she allowed just the venous blood to be taken. So she's got creatinine of 100, EGFR of 70 and a urea of 8. Which is about stable compared to what it was when she left hospital last time. She's got a sinus tachycardia. And you suggest seeing if she would give permission for the PLN to call her friend to offer some phone support. And the PLN's also going to go and speak to her about what helped her during the previous admission, if anything, and to kind of discuss with the A&E doctor exactly what's needed, how urgent is the ABG, what's going to be the next step after that, just so it can kind of spell it out for her and help manage her kind of expectations. Sorry,
I was going to say there's some good points coming in about how to support her to be as calm as possible. She's obviously feeling very stressed and anxious at the moment, and that's probably affecting her ability to discuss the plan going forward.
Definitely. So anything we can do to kind of slow things down a bit and give her some time to think through what's about to happen. So you end up suggesting some lorazepam following discussion with A&E. You feel that that's kind of a safe sedation to use. They're going to monitor her respiratory function and everything, but they want to try and get this ABG and kind of move on with her treatment. So you do that and you head off to see the other patient. So back in the office, the PLN then tells you that Ms. T had the lorazepam and was a bit calmer after that, and she gave the PLN permission to call her friend and also was able to speak to her friend on the phone, and that seemed to help. It seemed that Ms. T was quite worried that the doctor was going to actually put an arterial line in, and she was thinking that she was kind of maybe even having to go back to ITU or something like that. And she hadn't really taken in what had been told to her. So eventually she was able to have the ABG very quick, and the PLN supported her with that. So she's been given the treatment dose enoxaparin, and she's going to be admitted medically for monitoring. She's still awaiting her CTPA. Her more bloods are coming back. So she's got negative troponin, everything else sort of not too bad. CRP's not raised. Her blood gas has come back as well. And the PLN has seen her again with the ED reg, and kind of she's agreed to come into hospital after it was kind of stressed to her that she wasn't kind of very, very unwell at the moment, but it was a kind of process of monitoring. She didn't need to go back to ITU at this stage, and they agreed to put her on the liaison list for review tomorrow, and don't think she needs a one-to-one. So the following day, you bump into the A&E doctor who saw Ms. T, and she tells you that it turns out Ms. T did have a kind of multiple subsegmental PEs and a resolving pneumonia. And you find yourself wondering, as a naturally curious person, whether Ms. T's DVT PE is related to COVID or her recent medical admission, and how long do people stay at increased risk of thrombosis after infection with COVID? Does anyone have any thoughts on that?
So a few points here, commenting on her mobility. We know that she does have reduced mobility compared with her normal functional status. And a few people saying it quite likely is related to COVID, and a bit of uncertainty around how long that risk persists for after someone's been treated and the COVID is resolved.
Yep, and I guess, yeah, as people are pointing out, it depends on her other comorbidities as well. So, yeah. Right, so I think, as we've kind of said before, a bit sick of me talking about VTE, but, you know, we have the Dutch study that initially came out of an ITU at the beginning of COVID, and that was a kind of really concerningly high rate of thrombotic complications, because these were patients that were already on prophylaxis. So there are kind of issues, as we've talked about, with kind of inflammation, immobility, dehydration, possibly some direct effects of COVID. So what people have been seeing is not just large thromboses, but also kind of small thromboses in capillaries, which seem to lead to lung damage. But the jury's still out really on kind of how much to give. If people are at very high risk and in ITU, some places are using intermediate treatment doses rather than prophylactic doses. And then there's also some arguments for ongoing prophylaxis after people leave hospital. There's the International Society of Thrombosis and Hemostasis, which have published some kind of consensus statements, but again, it's kind of 30% of people surveyed agreed with this plan. So it's kind of, but it does seem to be many places are giving things like rivaroxaban or Clexane after discharge for kind of a week to 2 weeks, but no one knows for sure. And for us, I guess, again, the key thing is to screen all inpatients for VTE risk when they come in, and if there's any change in their kind of physical health status, like they become positive for COVID and they're isolating and they're dehydrated and they're, you know, so that's on the Trust internet. So, because there's no rest for the wicked, you're working nights over the weekend and you get a call from the medical SHO asking if you can come and section someone on the medical ward. So Ms. T is demanding to leave the ward and saying that she can't take it anymore. She's saying to the staff, "You're going to kill me," refusing to speak to them anymore and just saying, "Please let me leave." She's not letting anyone check her vital signs, but they were last done earlier in the evening, and she had kind of reasonable stats, off oxygen, was afebrile. The medical SHO has tried to give her some lorazepam, but she's refused. And the medical SHO feels like he's struggling to really assess her capacity because she's not really wanting to speak to him. She seems very paranoid. And he's kind of also saying to you, "Can't really deal with this right now. Actually, we've got a medical emergency in the other bay. Can you just come and see her?" So what's your approach to this situation?
So some thoughts about assessing her capacity at this point and thinking about what sort of risks she's presenting. So for anyone that's just joining now, she was admitted for breathlessness in the context of a recent admission for COVID, and was found to have a PE on assessment. So she's been admitted for treatment of PE.
So, and definitely some thoughts about, you know, it's quite an abrupt change in her mental state. So are we dealing with a delirium? Yeah. So if there's time, which it sounds like there might not be too much of that at the moment, but you want to try and look at her recent notes and recent reviews. Think about, you know, what is keeping her in hospital at this point? Does she have to stay? Always a reasonable question to ask. And do we have reason to suspect that she might lack capacity to consent to remain in hospital? And could this be due to an impairment of mind or brain? Or is she suffering from mental illness? You know, she may well be hypoxic, she could be paranoid, delirious, depressed, anxious, or any combination of the above. And we know that she had anxiety kind of coming into hospital, so has that kind of got worse? And what are the risks and what could be going on?
It has been pointed out that it sounds like the situation on the ward sounds a bit tense at the moment with another medical emergency going on.
Yeah, definitely, definitely.
Any other thoughts?
Yeah, definitely. So thoughts about optimizing the environment. Finding somewhere quiet to talk on a medical ward is one of the greatest challenges of liaison psychiatry. We've all been offered cupboards to do interviews in, but yeah, definitely it's worth persisting. So yeah, could she have PTSD from past admission? And a very good thought about, could her friend help again? Always useful thought. So, yep. So when you look at the notes, you see the PLN has been to see her the day before. Her COVID swabs come back negative. And at that time, she seemed like she was doing okay, quite subdued though, very disappointed to be back in hospital, feeling quite anxious, but kind of quite keen to say that she was okay, really didn't want to talk for very long, and she's quite tired. And she said that she sometimes wished that she hadn't survived COVID, but she doesn't have active plans to harm herself. The friend's been in touch with the liaison team and is quite worried about her, saying that she's really struggled since she left hospital. She's really not her usual self. She's got a history of depression, and you know, there's a sense that maybe she's depressed again. OT and physio have seen her on the ward, but she's still desaturating a bit on exertion. They're going to do some further support with her and think about discharging her after the weekend. And the PLN was planning to ask the psychiatrist from the liaison team and the psychologist to come and see her to get some advice as well. And just a reminder, we looked at her ITU notes before, but we know that she was given some haloperidol and midazolam for agitation and paranoia during her ITU admission. And they did document that she had delirium, but there wasn't really any further details. And again, we know that the physio from the community team is a bit worried about her mood as well. So you arrive on the ward and the medical emergency team are in the bay next to her. Curtains are drawn and there's kind of quite a lot of activity, and you ask the nurse in charge, as very helpfully suggested, whether there's somewhere else you can see Miss T, and they manage to find you an empty bay to go and see her. And you explain who you are and that you work with the PLN who she knows from the day before. She looks quite frightened and wary, but does agree to come with you. And by that point, the nurses have managed to attach a SATS probe, and she's kind of very hypervigilant and sort of flinching when the machine bleeps. But her blood pressure's okay, SATs are 94% at that time, respiratory rate 22. So what would you like to ask Miss T now that you've got her somewhere quiet?
Right, so some people are going to be asking her about her mood. Checking her orientation seems sensible. Yeah, certainly a quick cognitive test if we're thinking about delirium. Yeah, and whether or not she's orientated. Anything else you'd like to explore with her? Question about whether she's having flashbacks to her time in hospital with COVID. And trying to understand what it is that she's experiencing and what is it that's making her feel frightened.
Definitely. Very good questions.
Yeah, absolutely.
So you ask her how she is, and she looks very kind of stunned and frightened, and you kind of offer comments about, you know, how frightened she must be to be back here again after everything that's happened. And she doesn't say anything for a while, but after a kind of a little while, she tells you that she thought that when the crash team were coming, they were coming for her. And she doesn't remember much of her time in ITU, but she does recall a conversation where they told her that she needed to have a tube down her throat and also feeling like she couldn't breathe. She recalls kind of choking, falling, images of knives coming towards her, thinking that the nurses were trying to kill her and feeling like her limbs were being cut off. And even after she left the ITU, she actually still thought the nurses were trying to kill her, but she kind of hoped that if she didn't say anything, she might just be allowed to kind of leave hospital. And she's still seeing knives coming at her. She kind of can't sleep because the images kind of appear when she closes her eyes. She has nightmares when she does sleep. She's having panic attacks almost every day. And when she got home, she just wanted to forget everything to do with COVID, but of course it's impossible and it's always on the news. And she feels very tired all the time. Friends are kind of checking in with her, but she can't talk to them. She feels really disconnected. And she really wanted to just get back to work to try and distract herself, but actually her concentration is really poor. She can't really remember anything. So what else would you like to ask her at this point?
So some questions around her, whether she's having suicidal thoughts at the moment, and also trying to check out what her understanding is of what she's experiencing at the moment. Some good points coming in about whether she's having nightmares. And Kate suggesting, what does she think might help? Does she have any ideas about what she thinks might make a difference?
Definitely. And what would her support at home be like if she was insisting on discharging herself? You know, hypothetically, what would home actually look like, and how would she manage? It's always definitely.
So questions about whether there's avoidance behaviours, whether she's been avoiding going out to work. I think that's a bit difficult because she's still being rehabilitated from the recent COVID admission. And questions about safeguarding as well, and this is something that's been coming up in the chat box about the history of domestic violence and whether there's any current concerns. I suppose it's possible that if she's fearful of going home, that might be feeding into her presentation at the moment.
And yeah, a really good point about how much does she understand about the medical impression of her treatment, and does that match with kind of what's been said to her, or, you know, is there a mismatch? Yeah, very good. Okay. So just some thoughts, I suppose, that we had were kind of a very good question, I think we've talked about it before, for people on medical wards, was just like, what was hospital actually like? Because people have very different experiences of hospital. And, you know, I guess she's had a quite traumatic experience. So understanding that could be helpful, and allowing her to talk about that. Normalizing her distress and kind of identifying that probably a lot of what she was experiencing was due to delirium, back with the kind of knives and that sort of thing. Exploring her mood, the flashbacks, other re-experiencing dissociative symptoms, how she's coping, what support she has, and as you guys have pointed out, suicidality, and psychiatric history. Personal history, I guess, is in brackets because, you know, it is the middle of the night. It's not always appropriate to kind of delve too deeply, but sometimes people do volunteer information to you that's very helpful. So she tells you that she feels very numb, cut off, spaced out, but then other times quite guilty, feels like she should be grateful for surviving, but she also feels broken, feels a bit like it was her fault that she got sick because she knows that she's got obesity and diabetes, and that put her at increased risk of COVID, or severe illness with COVID. She's kind of asking, you know, what good am I now? And she used to drink alcohol quite heavily, but she hasn't drunk for 20 years, and she's thought about it, but hasn't, because it will only make things worse. She took an overdose when she was 17, things going on at home, doesn't want to talk about it now, and then again at age 28 after a miscarriage and an abusive marriage, which ended at that time. But she did have 2 years of psychotherapy with a training therapist after that second overdose and found it very helpful, and hasn't had contact with mental health services since. Lives alone, very focused on work, and really worries about what she'll do if she can't get back to work. So, different font, interesting. So we've got an overweight Caucasian female. She's wearing a hospital gown, very tearful, but rapport improves as with the time that you spend with her. She's quite hypervigilant and easily startled. Her speech is normal, but she does have some word finding difficulties, which she's frustrated about. Quite anxious affect, fearful. She's not got any formal thought disorder. She doesn't actually believe now that the nurses really want to kill her, but does feel frightened on edge. She does feel that life isn't worth living now, but she hasn't got thoughts of kind of actively harming herself, but sometimes wishes she died or could fall asleep just because she's so exhausted. She sees knives sometimes coming towards her, as we talked about, sometimes blood on her arms, also kind of sensation of difficulty breathing and choking, but no other kind of auditory hallucinations or other psychotic symptoms. And she is reporting poor attention and concentration, and she does appear a bit distracted and hypervigilant, but she's kind of orientated to time, place and person, and she's able to recall your name back to you. So, yeah. So what are your differential diagnoses at this time? Ideas of reference, sorry, bad. I mean, Lynsey always says I put too many words on the slide anyway, so I always try and shorten it where I possibly can, but you know, it doesn't make that much difference.
So we've got a few different thoughts coming in, suggestions of delirium, psychosis, anxiety disorder, adjustment, quite a range.
Well, that's psychiatrist for you.
Could be an acute stress reaction, an adjustment disorder, or depression.
Mm-hmm. So definitely lots of votes for adjustment disorder.
Mm.
We'll come to the formulation a bit further later. So one vote for PTSD. Oh, God. So this was the kind of list we came up with. So PTSD with or without kind of psychosis, adjustment disorder, depressive disorder, anxiety, delirium, psychosis. Again, it's the middle of the night. We may not quite get to the bottom of it, but yeah, this is kind of where we're.
And quite rightly, it's been pointed out that this really needs longitudinal assessment to get a real sense of what's going on for Miss T.
So, on to kind of morbidity post-ITU. So, another acronym, PICS, is post-intensive care syndrome, which is a kind of well-documented issue that can kind of develop after a prolonged period of critical illness, and it's kind of new or worsening impairments in physical, cognitive or mental health. And I suppose for us to know, cognitive impairment is very, very high after critical illness. There's varying figures, but up to a third of ITU survivors seem to experience PTSD, which is of a clinically significant level. Depression in up to 31%, and physical impairments are variable but range kind of from exercise intolerance to kind of sexual dysfunction and pain and that sort of thing. So people aren't quite out of the woods when they leave ITU. When we think about post-ITU PTSD, there has been kind of increasing interest in this over the last kind of 10 years or so. Of course, it's the same kind of criteria as for any other type of PTSD, but when it comes in an ITU population, it's associated with worse physical health and decreased quality of life and functioning, although that's probably true for all people with PTSD. Critically ill patients are at high risk for a number of reasons. So they're having life-saving treatment, but those treatments can be very invasive and disturbing, even when they're done with good intention. So things like intubation, ventilation, catheterization. And people are in a position of not having control, sometimes restrained, problems with communicating if they're ventilated, thirst, hunger, deprived of sleep in a noisy environment with no natural light, and then lots of use of psychoactive drugs and delirium, as well as witnessing the death of others. And the risk factors are sort of having delusional memories of ITU, so having had a delirium whilst in ITU, lots of high use of sedation, which could be just because someone's delirious and then they're getting given more sedation, or the sedation itself is a risk factor. Psychiatric history, young age, being female, having mechanical ventilation and a lung-related kind of ITU admission. And of course, we know from other groups that prior trauma and immediate reactions to trauma also predict PTSD. So, I mean, I suppose some of these things are really obvious, but I guess because we're kind of helping people, we don't necessarily think that you know, that these things will be traumatic perhaps, but the moments where you kind of given bad news, or where you're having invasive medical procedures, seeing, hearing, learning about other patients dying, or kind of witnessing other distressing behaviour and hallucinations are all things that can kind of be traumatic. Yeah. And the studies that have done kind of qualitative research into what post-ITU PTSD is like is actually that there's a vast kind of more of the memories and hallucinatory experiences are delusional and are kind of related to delirium, whilst kind of only about 12% are kind of factual memories of invasive procedures. But what tends to happen is actually that memories get kind of merged with real things that have happened. So there's kind of bleeding, choking, you know, persecution and that sort of thing merges with the experience of what was happening in the ITU at the time. And then there's also this kind of idea that you can experience recurrence of intense emotions or physical reactions, which is described as this kind of affect without recollection, or by Van der Kolk, I suppose, as the body keeps the score in that we, you know, feel trauma in our bodies. And reminders, of course, for people that have been through this can be things like smell or beeping or sterile gloves or that sort of thing. This is quite a very vivid description of some of the delirium experiences that people have experienced in the US. So they've done this video on the Atlantic that's got some kind of very vivid imagery of what some people have described in their ITU delirium. So worth a look. Although it's obviously horrific, so you know, not before bed.
No, certainly not.
And I suppose specifically thinking about COVID, well, why might things be worse in COVID? I know we're always telling you about how worse things are in COVID, but you know, we know that COVID has very high rates of delirium. We've got direct brain effects, inflammation, problems with communication, and we know that delirium is a really common presenting symptom. And that the delirium may be more severe, needing kind of higher doses of psychotropic medication, higher rates of mechanical ventilation, potentially more people witnessing the death of others, because actually the death rates in COVID ITU seem to be higher than ITU before COVID. And we know, of course, from the big systematic review that was done recently that there was quite high rates of PTSD and depression after SARS and MERS. And all of the things that ITUs have been doing to try and support people in ITU, like having diaries and ITU follow-up clinics, visitors, that sort of thing, many of those things are not kind of possible at the moment. And we know, of course, that also the people who are ending up in ITU may be people who have underlying health conditions or are from a BME background, who might have experienced previous traumas, which we'll talk about kind of a little bit more later. So back to Ms. T. So we know that she's a 58-year-old woman. She's been admitted with a PE and DVT, recent experience of critical illness secondary to COVID, complicated by delirium and ITU stay. And she's re-experiencing aspects of her delirium. She's got intrusive thoughts, nightmares, hypervigilance, panic attacks, fluctuating mood, passive suicidal thoughts, and she's finding it very hard, understandably, in the hospital environment. And she's got a history of depression and anxiety, and we think that she probably did have some trauma in her early years, and she's certainly a survivor of domestic violence. So how can we help her right now? But Lynsey's got something else to say. Have you? No? I thought you were about to say something. How can we help Ms. T right now? It's the middle of the night. What can we do?
So suggestions that in the longer term she's going to need support in CBT, potentially SSRIs, but clearly that's quite difficult to sort out in the middle of the night. So thinking about something sedative in the short term. Some other suggestions around medication to help her sleep, and a bit of psychoeducation around symptoms of anxiety. Some good suggestions as well about listening to her and helping her make sense of the experiences, and also normalizing some of the things that she's feeling right now. Some discussion around whether or not to admit, I assume, to a psychiatric bed.
Okay. What Dave said.
What did Dave say?
Dave said witness.
Oh, right,
and
yes.
Listen. Yes, definitely. I guess it's probably not that uncommon for people to have had medical admissions where no one's ever really asked them what it was actually like, and how did you feel, and let them know that it's okay to talk about actually how horrible it was. Because I guess, you know, we're clapping people as they're coming out of ITU and celebrating, and actually that makes it very hard for people to say, you know, what, it was horrible, and sometimes I wish I had died. You know, it's quite hard to say that. Anyway, so some thoughts about medication, maybe some antipsychotics, we'll see. Yeah. Okay, so she's feeling a bit calmer after she's spoken to you, and she'd still really like to go home, but she understands that she probably needs to stay until she gets the help that she needs, because she admits that actually she wasn't really coping very well at home. She's got very kind of limited exercise tolerance, so she does need kind of package of care and things. She's really exhausted, just wants to go to sleep, wonders if she could be put somewhere else, because it's still, the medical emergency is still kind of going on in that place that she was before. She wants to be discharged as soon as possible, but she's willing to stay, and she would quite like to see a psychologist after the weekend and see the PLN tomorrow. And you agree that you're going to get her something to sleep, maybe some promethazine, get her some earplugs, and see if she can have a side room. So thinking about how we support people that have been through trauma, and particularly related to COVID, there's the Centre for Mental Health briefing, which really stresses the importance of psychological first aid as a kind of first step. So the things that you guys have been talking about, like practical care and support, not being intrusive, but addressing people's needs and concerns, listening to them, but not pressuring them into talking, and helping people kind of access support and protecting them from further harm. And I guess that's kind of in keeping with what Judith Herman, how she would describe healing and recovery from trauma. So the first thing is really just about safety, safety from future abuse, giving people back some autonomy, letting them kind of be back in control, because one of the kind of core features is this kind of loss of control. So, yeah. So we've got this really helpful kind of link to Joe Stubley's paper on the Tavistock website about thinking about psychoanalytic approaches to COVID and the trauma of COVID. And I guess she points out that when we're under threat, you know, as humans, we're sort of primed to find safety in attachments if we have secure attachments. But of course, to survive in this situation, we have to do the opposite, which of course is the kind of paradox of the pandemic. And the threat of ill health and death is a kind of fundamental kind of anxiety of annihilation. And we've seen, of course, defences operating at individual and population levels, splitting and projection and the Chinese virus and these kind of things. But, you know, I think, and she stresses, of course, that the body keeps the score. As I think Anastasia pointed out, the book by Bessel van der Kolk is amazing, really helpful to understand how trauma affects the body.
And someone also said there's a podcast by van der Kolk as well, which I've not heard, but I'll definitely check out. Excellent.
So you don't hear anything about Ms. T over the next couple of nights, which is good. Things are kind of going well. You see that she's spoken with the PLN and they're just providing a little bit of support and checking in with her each day over the weekend. She's doing okay. The sleep's not great, but otherwise she's managing. So the following week, you're back at work and you look up her notes to see what's happened. She's seen the psychologist and the psychiatrist from the liaison team, and she tells the psychologist, she opens up a bit more about her past. She's not in touch with any family. Parents are both deceased. And she discloses that she was raped by her father's friend when she was 16, wasn't believed, and when she tried to tell her family, they kind of didn't believe her, and she took an overdose after that. She did find therapy in her 20s really helpful and is willing to consider it again, but she's really unsure, kind of can't quite see her way through this. Psychiatrist started her on sertraline because she said, you know, she had found that helpful. She'd taken it for her depression in the past. Started some regular promethazine to see if that can help with sleep. And she's feeling a bit more hopeful. And she's going to be discharged quite soon with an increased package of care. So you're attending the liaison psychiatry supervision group, and you decide to speak about Ms. T and some of the issues that have kind of come up for you over the time. So the first question is kind of what are the longer term physical and mental health issues for people who recover from COVID? So what do you guys think are going to be the kind of issues going forward? Sneak previews come through there. So it's just a question about whether there's any safeguarding. I think we've heard from her that she's living alone and she left the abusive marriage kind of back in her 20s. So from her, she said kind of that there isn't anything active at the moment. So I think that's probably okay. So people are sort of talking about prolonged anxiety, dissociated emotional numbness, yeah, sort of questions about where did you get the virus, who gave it to you, the stigma of being someone that has had the virus and worrying about giving it to other people. Yeah, definitely. Yeah, and long-term lung illness. Okay, so we'll skip on. So I think we've talked a little bit about this already, but we're expecting that there is going to be a lot of fatigue and depression. We of course know there's a link between inflammation and depression, and a link between kind of inflammatory disorders and chronic fatigue syndrome. Dating back to the Spanish flu, there was a lot of kind of neuropsychiatric sequelae after that. And SARS and MERS as well, ongoing fatigue. And I suppose worse for COVID survivors is that they're actually not returning to a society that was as they left it. So, you know, things are not as they were, and there is a huge stigma of kind of fatigue and difficulties in returning to work. Cognition, as we've already kind of mentioned, there appears to be kind of cognitive deficits with COVID, and long duration of delirium and severe delirium are also associated with that. So what do we think the follow-up options are for Ms. T? She's due to leave hospital quite soon, and she's seen the psychologist and the psychiatrist while she's been in, but what sort of support do we think she needs? She's going home with a package of care, so she's going to have people coming in and out, kind of helping her wash and dress and shop and that sort of thing.
Yeah, so some suggestions about CBT when it's available, and I think that earlier on people were talking about referrals to IAPT. Thinking about family support as well, we know that Miss T in particular doesn't really have much family, but she does have one supportive friend who's been quite involved in supporting her.
So I guess, as we mentioned very briefly, post-ITU clinics are a fantastic thing, although there's variable provision at the moment because obviously, as you can imagine, ITU's been pretty busy just working in ITU. But the things that they would do is a multidisciplinary review, as well as sometimes an opportunity to go through an ITU diary to help fill in gaps and make sense of experiences. At the moment, there's discussion about for PTSD, will IAPT be providing supports, or will they go to secondary care psychotherapy services? But for now, the psychologist that we asked kind of to review the case suggested probably initial referral to IAPT for support might be sort of for a brief intervention, a supportive intervention, and later down the track, if she was going to need some trauma-focused work, then that would be, we'll see where that kind of comes from.
Sure, and that's very much reflected in the comments for everyone saying they would refer to IAPT.
Yeah, definitely. Also, you'd access that more quickly, yeah, certainly, but as an initial starting point. And peer support as well. So there's telephone befriending in some areas. There's some online support groups for people who've left ITU. And Lung Foundation and that sort of thing. So I suppose just to stress, we're offering her initially a supportive intervention that's going to be kind of led by what she wants, and keeping in mind that she certainly has some post-traumatic symptoms that she may want to address down the track, but not kind of forcing her into that.
Absolutely. All right.
Okay, so again, PTSD post-ITU, again, a lot of the evidence focuses on prevention, but also the NICE guidance suggests that people should be offered psychological support, reducing sedation, follow-up clinics, that sort of thing, and therapeutic environments in ITU are helpful. But again, post-COVID clinics, post-ITU clinics, you need to check your local arrangements. Yeah. So, last and most important point, maybe. I think so. How can we support people who've experienced trauma to receive medical care? That's quite a big question. We haven't got much time left, but if you guys have thoughts about how we can support people like Ms. T to access medical care.
Yeah, I might just skip on with this one so we can cover all the points we want to talk about, but please do keep giving us the feedback, keep the comments coming. All right, so let's talk a bit about trauma.
George, so I guess I think we probably know what the definition is, but I guess helpfully SAMHSA have kind of outlined all of the different types of trauma, which I think are worth thinking about, because obviously we tend to think about perhaps adverse childhood experiences, but we know that prejudice, racism, caring responsibilities, bereavement, survivorship, certainly migration and asylum, or trying to seek asylum and the processes involved in that are traumatic. So I think there's many different types of trauma.
So I suppose I'm just a bit mindful of time, but we just want to highlight the ACE study is obviously one of the sort of seminal pieces of work in this area, really huge survey-based piece of research that looked at adverse childhood experiences and identified that across the population in the States, 52% of respondents had experienced one or more adverse childhood experience. And they identified a dose-response relationship between these ACEs and quite a number of comorbidities and health complications, including ischemic heart disease, cancer, chronic lung disease, fractures, and liver disease.
And I guess just highlighting again the dose-response relationship. Might just keep moving. And I guess, the other thing is that beyond ACEs, there's been links to kind of many other disorders, or almost everything as far as I can tell. But I guess important to stress that actually the people who are being treated for severe COVID have many of these issues. So the overlap and kind of degree of trauma may be quite high.
Racism also affecting health in multiple ways. I suppose there's a whole range of things here that have been identified, but I suppose the main ones would be the structural and institutional effects and segregation, unconscious bias. And I think what's really been highlighted this week, I've seen a lot of talk about lack of teaching in medical schools and how that has these really far-reaching effects. And also the effect of discrimination on mental and physical health. And, again, there's been quite a lot of study done in this area to sort of back up that evidence.
And I think it's similarly to kind of adverse childhood experiences. There's a huge overlapping area, but the neurobiological and direct kind of effect of trauma and kind of discrimination and things that it, affects cortisol. Cortisol affects the developing brain. That's been shown kind of time and time again on kind of brain scans and kind of effect on inflammatory markers and that sort of thing. So there's a direct effect of these things as well as the other effects through kind of coping strategies and other social determinants of health. Okay.
Yeah, I think we're just going to talk about this really quickly, but what does trauma actually look like? Well, there's a whole range of things, hypervigilance, shame, dissociation, coping and symptom control. Frequent attending is one that comes up quite a lot, and the other side to that is people that never attend and never seek support. Medically unexplained symptoms, also quite a common one, and poorly managed chronic conditions, and we see a lot of multimorbidity, in some cases refusal of treatment as well. So why is healthcare re-traumatizing? Well, I suppose there's quite a lot of reasons for that. We do quite a lot in healthcare, but some of the really important ones to highlight are the power dynamics that we sort of take for granted and I think often forget about when we're working with our patients. We're doing a lot of invasive procedures, and that's particularly true of people in ITU. And there's lots of things that, again, I don't think we think about as much as we should, but taking off people's clothes, physical touch. We talked a bit about things like catheterization and other invasive procedures. And very personal questions where we just sort of expect people to willingly and comfortably give up all this information that they often don't share with anyone else. Lack of privacy and a loss of control. And, healthcare does require a huge amount of trust in authority figures, which for someone who's experienced trauma can be really re-traumatizing. And also, the lack of BME representation can be quite significant. And when people have experienced previous discrimination and then come back into a healthcare system where they're being discriminated against, again, that can be pretty re-traumatizing as well.
So SAMHSA gives us a guide to kind of trauma-informed care, which essentially is about realising how common trauma is and understands how people can recover. It recognises when people might have been traumatised and it responds appropriately, and it tries very hard to resist re-traumatisation. You can read a lot more about that.
Yeah, do take a look at the links. There's quite a lot of really useful stuff on there.
So essentially it's about empowering people, it's about giving people choice and collaboration, creating safe spaces and doing kind of what you say you'll do. And I guess that's both in kind of inpatient mental health settings, but also in kind of liaison settings. We can help empower people and, like with Ms. T, try and at least put her back in some control over what's going on in a situation that feels very out of control. So 2 weeks later, she's discharged with a package of care. She's having ongoing rehab. They're going to refer her to IAPT. She's still on sick leave, but she's starting to Skype her friends again. She's had her dog around to visit in the garden. And she's reading some poetry because that's what the OT suggested because it works okay with her short attention span. And she's joined an online support group. So things are looking up a little. So I guess, as we've kind of talked many times before, there's lots and lots of kind of neuropsychiatric sequelae after COVID, and there's the potential that these will be higher after ITU admission and affect someone's health generally and their ability to receive medical care. And medical care itself can be traumatizing, and we have to kind of admit that and kind of appropriately deal with that. And critical illness and delirium make that much worse. And COVID in particular, I suppose some of the support which might have helped minimise the trauma of ITU and hospital might be less available, but there are ways that we can support people. So a big thanks to our expert reviewers. Again, we had a fantastic cast of many different people helping us with this one, and also for Millie Smith for putting us in touch with the people from people participation. Yeah, and the Meta team as always. And yeah, sorry.
Survey.
Oh yeah, the survey.
Oh yeah, so we would really like your feedback on this webinar series. We've been asked to try and I guess process it and understand what was helpful about it, and your suggestions.
Oh god, that's depressing.
Yeah, we would read emails out to most people that are on the distribution list, and if you could take a look at that in the next day or two, that would be amazing. Thanks very much.
Thanks guys, thank you so much again to all of you for participating. We've really appreciated your contributions today and for the whole series, and thank you again to Cate and Lynsey for everything that you've done for us over the last 3 months. Thank you so much, you've been amazing, really outstanding work.
And all I want to do, Juliette, is just repeat what you've been saying. Thanks, Cate and Lynsey, for all the work you've done, and Juliette, you two, for coordinating this. It's been absolutely superb work. I feel like I've been at 9 out of the 10. So I've been to most, I just missed one. And they have been absolutely fantastic. The interaction's superb. I think you're getting loads and loads of thanks already on the line. So thank you, and please, please, please keep the good work up. But well done. Take care.
Thank you.
Thank you. Do we have anything else to say?
No, just a massive thanks to everyone that's been involved. I suppose we've had this huge number of people contributing to the cases, and every single one of them has been brilliant. So thank you so much, everyone. Take care and stay safe, I guess, and don't forget to fill in the survey. Bye.